This program is brought to you by Emory University.
Good morning, everyone. Thank you so much for joining us today. Today we have Dr. Loyd, who's going to be speaking to us about wearable cardiac devices for cardiac arrhythmia evaluation. Dr. Loyd is a graduate of Meharry Medical College, did his residency in Miami, and now he's a second-year fellow here at Emory. Take it away.
Hi, how's it going, guys? It's happy to be giving this presentation this morning. Yeah, so I wanted to kind of go through a case first, and then kind of talk about the current opinions and kind of data that we have on using wearable devices in the management of arrhythmias or evaluation of arrhythmias. So jumping right into it. This is a case of a gentleman, 64-year-old gentleman, history of severe AI, had a SAVR with a biopostulant aortic valve, actually twice, hypertension, hyperlipidemia, was experiencing like occasional palpitations for like a few weeks. I think he said maybe like 6 to 8 weeks. But they had been getting like an increased number in frequency and duration. And they were very like symptomatic with the palpitations. He would become like very blurry vision, dizziness, lightheaded, almost felt like he was going to pass out, almost pre-syncopal in nature. And he had noticed they had become more frequent, like 2 months to prior to him coming in. Fairly active guy, exercises, pretty active multiple times throughout the week. Only medication change he had was that he had started Ozempic prior to coming to the hospital. So he has his Apple Watch, and I guess like on the Apple Watch that he had, he noticed that his heart rate would shoot up to like 150s, 160s. And at that time he would take readings like on the newer Apple Watches they have where you have this crown on the side of it. And you're able to generate an EKG, which he did. And he had those tracings with him when he came to the ED also. But got to the ED, wasn't having any fevers, chills, no nausea, vomiting, diarrhea, chest pain free, no shortness of breath at the time. And his heart rate was fine when he came to the ED. Like I said, this is his past medical history, family history. He had a father that had an ICD for a cardiomyopathy who he believed was due to myocarditis. And then the only other thing was he had a child that died of a brain aneurysm rupture at the age of 10. Social history doesn't do much. Alcohol, no alcohol use, no tobacco use, no recreational drug use. And then he works as a general manager for a security company. These are his list of medications. Like I said, pretty standard medications that we prescribe patients, nothing really out of the ordinary. And then, like I said, the most recent one that was added was Ozempic for him. So in the ED, these were his vitals, pretty stable, afebrile, heart rate, blood pressure, pulse, oxygenation, all fine. He's obese gentleman. Labs relatively unremarkable, BNP of like 117, renal function fine. He had a MAG of 1.8, K of 3.7. Tropes are relatively fine also. And then he had a TSH that was done that was normal. A1C was fine. He had like a viral panel that was done. The only thing that was positive on the viral panel was his Coxsackie B6 virus titer was 1 to 80. These were the strips that he had on his Apple Watch, actually. So this was at 10:08 p.m. that night. You have this wide complex tachycardia, heart rate at about 162. At 10:15, it's still going on. Kind of subsided, started to have like these like runs of NSVT around 11:25 p.m. Was relatively fine around 11:30. And then again around midnight started to go back into this wide complex tachycardia that was lasting. Like I said, heart rates in like the 150s to 160s. And these were very symptomatic at the time. Like I said, he would feel very dizzy, very lightheaded, feeling like he was going to pass out during these episodes as well. So this was what was prompting him to come to the ED initially. So this was his EKG on presentation. So he has no real like STT changes to be concerned for like ischemia, normal sinus rhythm, heart rate probably around like 75 on this one. He does have like these PVCs, which kind of give a clue to where this wide complex tachycardia could be coming from. So it's positive in like his inferior lead. So we know it's probably coming somewhere from the basal part of the heart. So that was at least one clue that we had. So the decision, so we decided to admit him to telemetry for monitoring, and essentially we wanted to get a CCTA to make sure this wasn't something ischemic in nature. If that was remarkable, then we would get a cath and an MRI to look for like scars. While the patient was on the floor, he actually had another run of this VT that was very symptomatic with the heart rate up to 200, that resolved with beta blocker therapy, but he ended up getting transferred to the CCU. This was this was the kind of rhythm that he was going in and out of during that time. Kind of very similar morphology of the PBC location that we saw in the prior EKG when he first came in. So it's very telling. So this was the read from his CCTA. So multivessel coronary atherosclerosis, cataracts 4A, 70 to 99%, severe stenosis, apparently severe proximal LAD stenosis, mid RCA calcified, and then moderate stenosis in the distal left circ. And the recommendation was for him to go for invasive angiography. And his bioprosthetic aorta valve was well seated, normal opening. So these were his cath images. I think hopefully these play. So this was his right system. So pretty clean right system here. And then this was his left system. Remember, this is where they called the severe stenosis in the proximal LAD. Also pretty clean. Vessel left main is fine. LAD looks fine. And then his circ looks fine also. One more time. So no real disease to suggest that this is the reason that he was having the VT. Okay. So next we did a cardiac MRI. So with the cardiac MRI, it showed they had mid-myocardial delayed LGE in the basal septum of the left ventricle. It was thought to be non-ischemic distribution and some edema concerning for myocarditis. But of course, they said sarcoid couldn't be ruled out, but less suspicious given the patient didn't really have any mediastinal lymphadenopathy. And his EF on the MRI was 43%. And again, his aortic valve leaflets of the prostotic aortic valve were opening fine. So the patient went for EP study. He had they were able to eventually induce like a monomorphic VT going around 170, which is around what his VT was on the prior like EKG and Apple Watch strips that he had. And it was suggestive that it was coming from the aortal mitral continuity versus like the left ventricular inflow exit site. The tachycardia was like easily pace terminated. So the decision at that time was to place an ICD and place a setting so that the VT, because during the study it was easy to pace terminate, that it could be easily pace terminated with the ICD as well, rather than to ablate at the time, because that particular area of ablation is very difficult. So this seemed to be like the best option at the time, given that like I said, the VT was able to be pace terminated pretty easily. So he actually ended up having a recurrence of his VT during a ski trip. There were a few events that were pace terminated, but he did end up getting one shock from that was not able to be pace terminated, so he got one shock. So went back to do EP study for him. Was able to induce the same VT that he had before. And this time they were able to successfully ablate the area that was causing it. And after aggressive induction attempts with coupling and isopro infusion, they were not able to induce the VT again. And this kind of just shows the area that it was coming from right here, the aorto mitral continuity. All right, so like I said, so this case was a gentleman that essentially, in summary, had a direct-to-consumer device that can provide an EKG reading, and the patient was able to record these and show his provider and be like, "Hey, this is what is going on when I have these symptoms. This is the rhythm," and then that kind of guided management moving forward. So there's always like discussion about how practical these things are with clinical application, the direct-to-consumer devices that we see. And so that's kind of what this discussion is going to kind of focus on. So one being discussing current types of wearable cardiac devices available for diagnosing cardiac arrhythmias. Two, kind of examining the advantages and disadvantages of direct-to-consumer cardiac devices. And three, kind of looking a little bit at the research that's been going on and future projected research to kind of focus on these things. So the current type of wearable cardiac devices we have, so we have smartwatches. So this is like your Apple Watch or Fitbit. I think probably everybody has an Apple Watch. And like the newer generations, I think from the Series 4 and up is the one where they have like the crown on the side here, where you can actually touch on the side, generate an EKG, similar to how the patient in this case did, and have those results available to show up at a clinician or provider or whoever you need to, if you're concerned about something. Like I said, the benefits of these are that they have the EKG functionality, and then they can monitor your heart rate. We also have portable Holter monitors. These are kind of more so like the old school things that we used to see, that you would wear for like 1 or 2 days, and then kind of have it read by your physician, and then kind of know the results of what's going on. Then here we have like these kind of newer things like these e-patches that Philips has that we use a lot at Grady, I know, or in general, I think. And these are allowed for more continuous monitoring. I think we usually do these for like 2 weeks to 4 weeks sometimes. It kind of just depends. But these are kind of what we're moving towards now when we prescribe them in our cardiology clinic. And then like I said, you're able to wear these for a longer period of time than you were with the Holter monitors. You also have the Zao patches that you can wear, and then these cardio devices you may see patients have also are another direct to consumer device that patients will often ask you about, which are also kind of like devices similar to the crown on the Apple Watch, where they can touch and then they can generate a EKG whenever the patient is having symptoms or whenever they're concerned. And of course, these are like lesser known things. So these are like biosensors. So they measure like different kind of like aspects of like your health. So blood pressure, oxygen, some of them also like measure like muscle contraction. So those are some newer things that are also out as well, that are often, and all of these devices, the newer ones anyway, are usually integrated with smartphones. So you can record the data, send the data, share the data with whoever needs to see it. So those are kind of one of the benefits also. So the advantages of wearable cardiac devices. So continuous monitoring, you get real-time data collection. You're able to trend analysis of these, the data that you get from them. Early detection, so identification of arrhythmias before symptoms arise. I mean, of course, in this patient, like his symptoms came with the arrhythmia, but in certain patients that have like atrial fibrillation, which is what most of these devices have been studied for, you're able to know earlier if these patients are having that particular rhythm and kind of managing them a bit sooner. Patient engagement. So patients, when they have these devices, they feel more empowered because they feel like they have a little bit control over what's going on with them as far as their health. And it kind of helps to create that kind of clinician-physician rapport with patients. Especially if you're able to like talk to them, kind of discuss with them what's going on, if it's something they should be worried about, if it's something they shouldn't be worried about. And then accessibility, like these are much easier to get for patients than having to come to the doctor that's probably scheduled an appointment like 6 months down the road and having to get a Holter monitor versus like them being able to get this device, and kind of seeing if we're looking for something specific. This is much easier for them to get access to than probably some of the more harder things to prescribe for us. Some of the disadvantages of wearable cardiac devices. So data accuracy concerns. So there's always the concern that especially like with the Apple Watch, they can give a lot of like false positive, false negative results because it doesn't really account for like the motion artifact with a lot of those things. I know like with the Fitbit, when they will not record usually a reading, I think for the most time we're given an alarm unless the abnormality is going on for like I think like 30 minutes or like an extended period of time. The over-reliance on technology, yeah, so there's always the risk of missing a clinical assessment. Like if the patient sees that, hey, like I see this on my watch, I feel fine. I probably don't need to go to the doctor to, have this checked out. That's another thing. Privacy and data security. There's always concern about data breaches with patient data. So, especially like with cell phone companies, it's happened in the past. So that's always another thing. So it's not as HIPAA compliant in terms of like the data that we're gathering with these particular devices. Compliance issues, and of course, like patients, like you're not. So a lot of patients, they're not always going to wear their Apple Watch or their Fitbit. Usually, a lot of times they wear it when they exercise, when they're at work, when they're like active, but then they take it off at home. So that kind of continuous monitoring component can be kind of jeopardized in that regard. So direct to consumer cardiac devices, like we said, so these are the devices that are easily available to patients. So like smartwatches, mobile ECG devices, like that Cardio Mobile device that we talked about. And so the advantages of direct to consumer devices. So like I said, you have immediate access to monitoring without having to go to a healthcare visit. Again, in that healthcare visit, having a copay, maybe having to pay for different things like during that visit itself through the insurance company. So it's usually a little bit more cost effective for patients to have these direct to consumer devices than having to like go to the doctor and get devices prescribed and that being charged to like their insurance. And then again, it increases the patient's awareness of what's going on with them. So they're more proactive about monitoring their health in this regard and then other aspects as well. But again, like I said, some of the disadvantages of these devices, so limited clinical validation for these. They may not be rigorously tested like prescribed devices, such as like the Holter monitor or the Xylo patch or the loop recorder. There can be misinterpretation of data by patients themselves. So both on the side of being too anxious about something and then again not knowing what's going on with the rhythm or the findings that they're seeing and not being able to adequately kind of interpret what they need to do as far as next steps. And then inadequate follow-up. So lack of professional oversight for abnormal results. So like if patients have abnormal rhythms, and if it's going on for like short period of time, versus like a longer period of time, like kind of knowing like at what point they should reach out to their provider. That's something that can cause like inadequate follow-up as well. So that's another one of the disadvantages of those devices. So in terms of like research directions, so longitudinal studies to assess long-term effectiveness of patients and outcomes is something that they've been trying to do with the Apple Heart study, the Heartline study that they've had in place. Regulatory frameworks is like still something that's very like new. It's very new research. So, kind of having that framework for regulation of these devices and being able to like clinically apply the data that we get from them is something that's still like relatively new. Patient population studies, so understanding diverse demographic responses to wearables. A lot of times like these devices they're more readily available, but they're not really available to all patient demographics. Patients that maybe make less or come from a more disadvantaged social economic status, they might not be able to have access to these devices. So that's another thing. Integration with health records, and then like I said, so being able to like link the data that you get from the Apple Watch, the Fitbit, the Cardia to your health record is another thing that will likely be on the books for research in the future. So like I said, so some of the main studies that have come out were the Apple Heart study, the Fitbit for AFib study, which is kind of like similar but using Fitbit, and then the Heartline study, which is one of the newer ongoing studies that kind of looks at this. Most of the study, although our patient had like VT, most of the studies have focused on atrial fibrillation in terms of the continuous monitoring in the outpatient setting. So essentially, the Apple Heart study was to assess the effectiveness of using the Apple Watch technology in detecting atrial fibrillation and monitoring heart health in a large population. It's actually one of the largest studies, that kind of looked at this, and it was, I guess, it kind of like changed the paradigm of how we like do research, because it was like the patients essentially like when they got the sign up for the study, they did everything like through their iPhone, and so it was much easier to enroll patients than it would have been like doing like how we normally do clinical trials. The criteria for this was to be age 22 and older. Of course, they used the Apple Watch. I think it was Series 4 or 5, if I'm not mistaken. It was one of the earlier ones that had that first had the crown on the side so that you could record the EKG. Um, and then like participants received regular notification and access to the ECG app for monitoring heart rhythms. And then essentially the findings were that of the 400,000 people that were enrolled in the study, 0.5% of the participants had detected undiagnosed AF, and around 10% of these patients, when they had EKG follow-up to confirm, had actual confirmed AFib. One thing to like note about this is that with this study, like if you look over here, you see like with the patient population, like the usually we think of like AFib having like happening like older in life, but even above the age of 65, only like 6 or 7% of these patients were kind of above the age of 65, which is when we see most of the AFib. And that is most likely due to the fact that usually like patients that are like younger are gonna like have these devices and kind of use them more readily, more easily than our older patient population, which is what AFib normally occurs in. Very similar study with the Fitbit for atrial fibrillation study. This was a very kind of similar setup to the Apple Heart study. Only like key difference was that this one didn't really use ECG interpretation. It kind of used heart rate monitoring. So if the patient's like heart rate was abnormal or irregular for I think like 30 minutes, it was in a notification that, hey, this looks abnormal. You should probably get this checked out. And then those patients would go to have like clinical evaluation, EKG to confirm. And the biggest like takeaways from this was that the sensitivity was about 85 to 90%. So that essentially meant that it correctly identified AF in a high percentage of people, but it was also very specific. So in about the specificity was around 90 to 95%, meaning that if the patient the device accurately identified when the patient did not have AFib as well. But also in this study as well, as you can see, like the patient population above the age of 65 at least was about 12% total. But again, like usually that's going to be the main patients that we're thinking of that have atrial fibrillation going on. So, and then this kind of just shows like the age distribution of atrial fibrillation in the patient population. So like I said, like above the age of 65 is where you're going to see most of the cases of AFib. But like with this study, like most of the patients that were, kind of enrolled and in the study were like less than that. So that's where the kind of the heart study came along. And so this study essentially is a prospective cohort study that's kind of looking at very similar, kind of criteria, looking to see if they can detect AF earlier. But it was specifically exclusive to patients above the age of 65. And I think they enrolled about 150,000 patients that they monitored for 2 years. I think they're coming up on the third year now, which is just like a post-study year. And the results of that should be published, I think, January of next year. Like I said, the primary outcomes that they were looking at was like time from randomization to clinical diagnosis of AF during that 3-year study period that they had. Some of the other things that they were looking at were time to composite of ischemic stroke, TIA, MI, non-CNS embolism, hospitalizations for heart failure or cardiovascular reason, and then all-cause mortality. Those are like some of the secondary outcomes they were looking at also. And like I said, the results of that study should be published in January of next year. And I think this one will probably be a little bit more, indicative of, does this actually help in patients that we see atrial fibrillation mostly in? Okay. So devices capable of detecting VT. So like I said, our patients specifically had VT. So a lot of the monitoring devices are specifically for atrial fibrillation. But occasionally some devices are able to detect VT. It won't call it VT or VF, but you can do the EKG and then you can have a provider interpret it, like this particular patient did, to see that if it's like a wide complex tachycardia, if you're concerned about AFib. So the Apple Watch Series 4 and later, the Samsung Galaxy Watch Active 2 and later are able to do it. Like I said, the Cardio Mobile and the Zao Patch are also other devices that are able to detect VT. But like I said, in a lot of the studies, like the focus was on AF, but future studies to kind of focus on arrhythmias outside of VT as the technology advances, as they become more advanced with being able to get the ECG patterns on the phone as well. I think there'll be more data that'll come out from that standpoint. So future trends in wearable cardiac devices. So a lot of this, like we have this whole newer generation of using AI and machine learning. So I think this is going to be a big kind of player. Like the direct to consumer market is going to be kind of a big player in enhancing data analysis and kind of a better market for detecting arrhythmias. I think the devices are getting smaller, they're getting extended battery life. So we're able to, wear these devices a little bit easier than we used to in the past. Like compare like a Holter to that we used to use to the newer e-patches that we use with Biotel and Philips. So like I said, the devices are getting smaller and easier to use. So, these are going to become more readily available for patients as well. Telemedicine and remote monitoring is another big thing that allows for these things. So, like I said, when we talked about being able to integrate these into the patient's health record, that I think that's going to be another kind of focus that we're going to be able to like move forward in the future. And then personalized medicine, I think, kind of tailoring the way we practice medicine to the patient's needs, what they have going on, and like I said, like these direct to consumer devices, they're still in their infancy in my opinion, but they're gonna be, I think, something that is gonna be a major player in the future. And we're gonna have to like, I feel like, know about these devices because patients, all of our patients are gonna have Apple Watches, all of our patients are gonna ask us about these devices, and they're gonna be something that we need to know about and to be able to kind of give guidance on how accurate the information that they're getting, is from those devices. So in conclusion, wearable devices are transforming arrhythmia evaluation. We have to learn to like balance the benefits and challenges of direct to consumer options as well. Like I said, these D2C like options are not going anywhere. So it's going to be something that we'll have to kind of focus on especially in our clinic setting when patients ask us about these things. And then like the future advancement of these devices are on the up and up. So I think it's going to be something to like look out for, especially like with the Heartline study coming out soon. And then as these direct to consumer technologies advance, studies focused on arrhythmia detection may change the interface of how we diagnose abnormal rhythms. Like I said, most of the studies have been focused on atrial fibrillation, but I think as the devices and the technologies advance, we'll be able to focus a little bit more on other arrhythmias as well. And that is it. Any questions from anyone?
Quentin Stan Sherman.
How's it going?
Good talk. Basically, though, the problem I have with all these things is artifact.
Yeah.
And
Yeah.
and if we can't get, is it possible? Are they going to try and get more than one lead out of any of these devices? Because we have monitors that give us two leads. We seem to be able to discern artifact better.
Yeah, so at least with the Apple Watch, it kind of gives you guidance on how to. So the Apple Watch itself, so with its crown, I don't forget somebody, yeah, like with its crown here. So this kind of when you do this when it's on your left arm and you reach over to the right arm, that's kind of giving you lead one. Essentially, the one that we mostly see when patients wear the Apple Watch on the left arm is we're seeing lead one. But they do give guidance on how to get like leads two and leads three as well. But they suggest like placing on your abdomen, on your left or your right abdomen or left abdomen, and then touching the crown with your right or left finger, and those will give you leads 2 and 3 as well. But in terms of like being able to like get like a full 12 lead EKG, I don't think we're there yet, or at least not as far as like what I've seen so far. The other thing, so some of the devices, like you mentioned, like Artifact is another big thing as well that with Apple, it kind of just takes everything as it comes. I think like in the Fitbit AFib trial, like I said, they had like this kind of, they wouldn't get notified of an abnormality until like 30 minutes of when the patient had stable activity to kind of make sure that there wasn't like some type of artifact, and then they falsely sent like a notification that something was abnormal. Versus I think like with Apple Watch, it kind of like just, they were sending notifications with a lot of like artifact, and that kind of may have like muddied the waters of what was going on with the patient as well. But yeah, future, I think one of the biggest things that they'll need to focus on is being able to like kind of quiescent some of the artifact that comes along with the patient user error, essentially. Let's see if there are any questions in the chat. Let's see here. Cardia home rest has a 6-limb lead. Oh yeah, that's true. The Cardia device does have 6-limb leads. But it's not wearable. That's the thing. You have to like, kind of take it out, put your fingers on it, and then get the 6 lead. But I think, if that were one that we were able to get to be a wearable device, which I don't know if that's something they're working on, it may be, that would be a benefit as well. All right. Thank you guys for listening. Have a good one.
The preceding program is copyrighted by Emory University.